Welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
Hi, this is Nina Liu from the University of Washington, Department of Otolaryngology. I'm here with Dr. Giulia, Daneshgaran, and Dr. Susarla, both from the University of Washington Division of Plastic Surgery. We're the authors of the article in Facial Plastic Surgery and Aesthetic Medicine titled Spontaneous Regeneration of the Ramus Condyle Unit Following Severe Avulsion Injury in a Child. This article discusses a unique case report describing a 3-year-old boy who sustained a dog bite injury resulting in avulsion of his entire right hemimandible, in addition to extensive soft tissue loss. The segment of avulsed mandible was explanted for over 12 hours prior to the patient arriving at our institution, and there was also extensive soft tissue loss precluding bone coverage, so decision was made not to reimplant the segment. The segment included the condylar head, coronoid process, entire ascending ramus, and mandibular body, with significant periosteum and masseter, as well as temporalis muscle attachments involved. The temporomandibular joint disc and synovium remained intact within his glenoid fossa. The patient was initially treated with soft tissue closure with plans for stage-free tissue transfer to reconstruct the mandibular bone. However, on repeat CT maxillofacial scan at about 10 months post-injury, surprisingly, it was revealed that significant regeneration of his bone within the mandibular condyle, coronoid, and proximal ramus was seen. Due to this, the patient's reconstructive plan changed from free tissue transfer to iliac crest bone grafting. And Giulia, I thought it'd be great for you to talk a little bit about the existing literature on this particular topic.
Thank you, Dr. Liu. There are several factors reported in the literature that are associated with spontaneous mandibular regeneration. Male gender, specifically, and younger age are both associated with increased odds of regeneration, age ranging from 9 to 28 years, which is what's reported in the most comprehensive literature review of what is a pretty relatively rare phenomenon. The first radiographic evidence of mandibular regeneration is typically observed between 2 to 4 months after resection or injury, and the predominant location of regeneration is generally noted to be the mandibular body. Exceptionally few cases describe the spontaneous regeneration of a well-shaped mandibular condyle and coronoid, as seen in our patient. There's a growing body of evidence in animal studies that challenges the hypothesis that the only source of mandibular regeneration are the osteoprogenitor cells located within the periosteum, and instead they propose that the articular disc is also critical in the regeneration of an injured or absent condyle, and these studies are currently undergoing.
That's great. And Dr. Susarla, could you please tell us a little bit about how this can affect surgeons' management of these rare, but not something that you might run into as a facial plastic surgeon or plastic surgeon in a busy trauma center, especially?
Yeah, this is a very atypical problem. Reconstruction of the mandible in children is challenging for lots of different reasons. The particular issues in this case are reconstructing not only the ramus condyle unit, but also a segment of the body, and as you mentioned, accounting for the significant soft tissue loss. So our initial plan was to delay reconstruction because the functional goals of reconstruction at this age match those that you would see in patients with severe forms of craniofacial microsomia, to reconstruct a ramus condyle unit to afford appropriate growth and development, to prevent a secondary asymmetry or minimize the degree to which that asymmetry would be problematic as children grow. The issue in this particular case is that the only options for reconstruction for a defect of this size, which is far greater than the often quoted 5 centimeter critical size defect, would be the need for a vascularized reconstruction. And even if you were to do a non-vascularized reconstruction, where to put the fixation? And the reason is when the child presented, they were 3 years old. So their mandibular permanent incisors have not erupted yet. Those teeth will erupt between the ages of 6 to 8 years. So any fixation that you do could have significant adverse effects on dental development. And this is a child who's already missing a lot of teeth in the mandible from the initial injury, so you want to make sure they have as many adult teeth as possible. So the decision making was to wait at least a year or two to see how the mandibular incisors erupt, to afford us an opportunity to have adequate fixation of these areas without injuring the permanent teeth. It was very surprising to see the regeneration of the Ramus condyle unit and the proximal portion of the ramus, because this, again, changes the paradigm from needing to do a vascularized reconstruction to replace not only the mandibular body angle ramus, but also to create a functional Ramus condyle unit with articulation with the glenoid fossa, which, as you both know, is very, very difficult. Having an opportunity to have a native condyle or a regenerated neocondyle gives you a stable temporomandibular joint articulation. And secondarily, it makes the bony defect smaller so that the likelihood of needing a vascularized reconstruction decreases, which is, vascularized reconstruction for mandibular defects in adults is, fairly common and often straightforward undertaking. In a small child who's had an avulsive injury of this magnitude with small caliber vessels, the microsurgery can be very challenging and recovery can be very challenging. So being able to have the same type of reconstruction, which meets the functional goals of having a stable craniomandibular articulation, and utilizing a non-vascularized bone graft like a blocculea crest bone graft, is considerably advantageous in this child, because they essentially have a normal condylar skull base articulation and you're repairing a smaller segmental defect in the body. And it's our hope, and we'll follow this over time, that this neocondyle will contribute positively to the patient's growth and hopefully lead to very mild residual asymmetry as he approaches adolescence and skeletal maturity.
Great. Thank you both so much for, discussing the background literature and also the implications of this case. It was a really interesting case, and hope the listeners check out the full article and images at the Facial Plastic Surgery and Aesthetic Medicine website.
We'd like to thank the authors for presenting their work, and thank you for listening. Catch you on the next one.